Hi, just around the public health advice and on the science on when masks are appropriate to, or I guess when it's appropriate to reduce the amount of times we wear masks, and I guess in the settings that we wear masks.
I don't know that I've got anything to add beyond what's been said. There'll be a time when we change the settings on masks, but they're useful because they reduce transmission from anyone who might have infection. We don't know the actual caseload out there. Obviously, we've got 9 days of zeros, which is absolutely fantastic. But there can be individuals who haven't been identified, and masks play a role both for someone who's symptomatic, but also in that 2 days before you're symptomatic, and it reduces the risk significantly if both the person who's infected and the person near them are both wearing masks.
Is there a number of active cases, for example, or 14 days of no new cases that you're looking forward to I guess changing the rules on masks?
Yeah, we'll look into the exact epidemiology and the cost benefit, if you like. But at the moment, we're not in a place where there are no close contacts who might still develop illness. We've still got active cases. That situation, I'm sure, will change over the next couple of weeks.
Brett, just with I think you said 4 active cases, how many of you actually more suspect are out there? I mean, at the start of this pandemic, you were talking about, there was 5 times whatever it might be showing up in tests. Is that still the case, do you think?
I think it's hard to know. It's fantastic to see the levels of testing that are going on. We do know that 20% of people on average require hospital if they're infected. So I think it's unlikely that there'll be significant numbers out there that are undetected, because they would end up presenting to the emergency department needing hospital admission. All of those individuals who've got suspected COVID are getting tested on arrival in acute health services. We're not seeing people being picked up by virtue of that. That said, there might be younger, healthier individuals in the population who might have very mild symptomatic illness or virtually no symptoms who don't require any kind of healthcare intervention that allow that transmission to continue. So testing remains really important for that.
So we're not at effective eradication yet?
Who knows? It's possible, but I think we shouldn't work on that assumption, because that would change the way that we behave, that would change the way we're going about testing, and the testing's a really critical element at the moment. So the best assumption to make is that there are more cases out there and that we need to continue testing to find them.
Is the sewage testing telling us whether there is cases out there, or is there a problem with shedding the virus still that we can't tell?
I mean, the sewage testing's been valuable. It'll be most valuable in about a month. There are many regional sites that are showing no virus at all, where our case data tells us that there are no cases as well. So that correlation of zero detection in sewage and 0 cases is really confidence building. We are getting some positives from our big western and eastern treatment plants. One or the other of those has been positive in the most recent sampling. That's not unexpected. They've got catchments of hundreds of thousands, if not more than 1 million. So I expect that they'll remain positive even after these last cases recover. It's been known that sewage can remain positive for 4, 5, 6 weeks after cases have recovered. But when you get down to very low case numbers, the amount of virus in sewage becomes harder and harder to detect. But you can probably detect it, a case per 10,000 in the catchment. So when all sewage is negative in Victoria, that'll be a really useful time to then monitor continuously. If anything pings positively, then we'll absolutely be investigating for cases out there and prompting people to get tested.
In terms of some of the rules going forward, in terms of indoor community sport, stuff like basketball and netball, can those sort of leagues restart, social leagues restart?
They will be. There'll be significant changes to indoor contact sport for kids and adults from the 22nd of November. So I think that's a setting that'll allow both the sport to resume and for a certain patronage to be there to watch as well.
Just with cinemas and food and drink facilities, why is there a difference between the number of patrons there could be in a theatre compared to the number of patrons who are allowed to be at a restaurant?
Certainly, in a theatre, you'll be sitting there for an hour and a half, 2 hours continuously. The kind of monitoring that is done in the hospitality sector, and the enforcement that can happen in that sector is greater. You're not going to have anyone walking through a cinema to check on spacing or the way that individuals are behaving there. I think it's an appropriate setting for this stage in terms of numbers and the density quotient. But it is an indoor space where people will spend quite a bit of time with complete strangers other than their immediate booking friends or family.
With hospitality venues, though, you can book for up to 2-hour bookings. In a cinema or in a theatre, you can possibly have ushers or close off seats. What's the difference between having that at a theatre and a cinema and allowing 2 hours, allowing people to be at hospitality venues?
I think there are elements where the registration of those who are attending, the hygiene requirements, all of the compliance and enforcement that happens in the hospitality sector makes it a little bit different to those settings. But they will also get to a point in time where we can have greater confidence that the numbers can increase as well. But it is that high risk environment that combines both indoor people who you don't normally know being in close proximity with you and that extended period of time that you're together.
Are you comfortable that we're in a position to restart international arrivals into Victoria?
I'm not the one to make the call on the readiness of hotel quarantine, but my understanding is that we're ready to go at whatever point that decision is made, and certainly the inputs that my public health team have made around infection prevention and control and the oversight and the key performance indicators for that are all in place and ready to go.
Did you think we would get to this point by now?
I did. We backed the modelling that we commissioned and supported. We weren't using just one input in that regard. We were also looking at the experiences of other jurisdictions that had gotten to those low numbers in terms of what that represented as a risk of resurgence and what the trajectory would look like. And that's what it told us. And I'm very pleased that that's been validated and vindicated.
Brett, what do you say to the people who say this couldn't be done?
I don't really mind. I'm just happy that we're here. I think if there's a lesson for anyone, it's that, science-based disciplines use empirical data and use really sophisticated modelling and other science-based, evidence-based inputs to try and make the best decisions. It doesn't mean that they're foolproof. It doesn't mean that there isn't some uncertainty in all of that, but the discipline of science is use evidence, use the robustness of the philosophy and art that science is to guide, and to be open to all of the new inputs as they arrive. And if there's new evidence that suggests that we should take a different tack on something, that we should change the advice and recommendations from a policy perspective, then we should do so. So it's not perfect. Nothing is perfect in the way that you formulate policy in this space, but it's been extraordinarily helpful to get us here.
Is there a decision on weddings? It seems like they're a little bit further behind. Is that because they've been identified as a higher risk?
There's certainly a higher risk. I guess the difference between weddings and funerals is that weddings, and maybe it's not true for everyone in terms of the pressing desire or need to get married, but it's something that can be deferred for potentially a later period. And again, after the 22nd of November, those settings I would fully expect to change, and booking a wedding beyond that date, I think will give a greater allowance for the numbers there. But the close proximity of people, again, people who aren't normally in close contact necessarily, means that it's been identified as a risk of transmission.
Premier, just on the point Lundy raised about returning flights, no.
Please. There are a lot of countries looking to Victoria at the moment, and I believe you spoke with Irish health authorities recently. What's been your advice to other countries and to other jurisdictions?
Certainly, we were sharing both our challenges and our successes. The stage 4 restrictions are not the science. That was the tool that was used, but the lesson from Melbourne is everything that we did in that time as we drove numbers down and having a deep understanding of the kind of settings that we needed to get to the numbers that we needed and what the risk was of resurgence. And so the stage 4 restrictions were the tool, but the way that we've worked on the turnaround time for pathology testing, the way that we've worked on reducing the time for case and contact management and outbreak management tools have been really fundamental. The agent-based modelling that has informed where we'd get to and how we'd get there. All of those things were shared with the Health Minister and other public health experts in Ireland. I've got an invitation to do a kind of virtual town hall with them and to have some other European folk speak in the week ahead. You know, I think if there are lessons for anyone, it's that it's achievable and that the real benefit is getting to those sustainable low numbers and using the lessons that you've learned over that period of time to keep them there. We've obviously learned a lot about what the challenging settings were: aged care, enormously vulnerable, and those amplifying environments of abattoirs and food distribution centres and other warehouse centres with a large working population who are very mobile. So all of those things are things that I've been very happy to share with the Health Minister in Ireland.
Just on that point, sorry, you said other European countries. Which other countries are?
I'm not sure. It's being hosted in Ireland, but they'll put the word out to whomever is happy to chime in at that time. It'll be relatively early morning for Europe.
Will those workforces that you just mentioned go back to full capacity now or soon?
I believe so, yes.
Okay.
And is that because sentinel testing in those work sites gives you confidence that there won't be, you know, another Cedar Meads type situation?
I think it's all of the things that have been put in place. So obviously there's the COVID safe standards that they're all meeting. It's the compliance and enforcement oversight that's happening. So I'm confident that both with the reduced transmission that we've got in Victoria, plus everything that they're doing right, plus the sentinel testing that's going on for those higher risk workplaces all coming together, that makes them, you know, able to operate at full capacity.
There are a lot of health workers who are still very concerned about the risk of spread through aerosol transmission and that they're not being given adequate PPE for that. Are they wrong? Are they overstating it? Or is it time to rethink the approach here and acknowledge that aerosol transmission is a real risk and therefore prepare our health workers accordingly?
I've never spoken against the risk of aerosol transmission. I think we recognise that there are aerosol generating procedures and aerosol generating behaviours and the setup of certain settings that make the risk of transmission, airborne transmission, greater. And so we do need to address all of the elements. But the primary one is the closeness of interaction and the PPE that needs to be worn for that direct clinical interaction. But ventilation plays a role, the patient flow, the workflow, all of the other behaviours around that. I think we've addressed that. The healthcare worker wellbeing task force is looking at all of those elements. So it's not excluding airborne transmission as a possibility, but it does recognise that close proximity interactions are the primary means of transmission, and so managing that and managing the appropriate PPE for those clinical interactions are the most important things. And the PPE advice in Victoria has always been at or above the national standards.
Premier, just to put on the returning international flights, have you had a chance to consider